Just wait for Julian. Oh, you're online. Okay, I think we're all here, so we'll get started. Welcome and public questions. We've got no public questions, but we do have a welcome. Tamina Ajmal is here sitting in her post she's expecting to take up soon as Chief Operating Officer. So welcome, Tamina, to your first board meeting at Berkshire Healthcare.
Thank you very much.
And I hope you enjoy it. Okay, apologies, any apologies, Jenny, do you know? Don't think so, but...
Just Julie Hill.
Oh, Julie, of course, yes, Julie's in the north today. Declarations of any other business or interest in the register? No, minutes of the last meeting on the 12th of April. Any corrections, please? David?
It's a small point, but perhaps an important one. I asked whether the ketogenic diet was consistent with NICE. I actually didn't ask that. I wanted to know that the service we provided was consistent with NICE guidelines, not the diet itself. If that could just be corrected.
Yeah, of course, we'll correct that. Thank you, David. Okay, action log. As far as I can see from the action log, it's everything's either done or in hand. Has anyone got any questions on that? No? Okay, in which case we'll get on to some more interesting stuff. Patient story West Call. Debbie, can I leave it to you to introduce?
Yeah, of course, Martin. So thank you to Dr. Sandhu and Ben Belice and Helen Powthorpe, who's also joined us to give a user experience perspective of West Call. So I will hand over to whoever, Ben or Sandy, whoever's doing the story. They're going to give us about a 10-minute presentation, then as always open for questions. Thought we haven't heard from West Call for a long time, so it'll be really nice to hear what's going on from a West Call perspective.
Thanks so much, Debbie. Okay.
Thanks, Debbie. Okay, I'm going to share my screen if that's okay.
Of course.
And okay.
Yeah.
So I'm going to start, and then Sandy is going to come in and talk a bit more detail, and then we're going to finish with our wonderful service user and head of dentistry, Helen. So West Call, hang on, why the page is not going down? Try this way. So West Call, out of our services, deals with approximately 75,000 patients a year, which in the context of Berkshire West practices is an above average size practice, if you were to look at it that way. We're open from 8:30 in the evening to late in the morning and all weekends, and we look after all ages. And oh dear, the presentation isn't displaying, no?
No.
Let me try again. Typically of all days, it would decide not to.
That's okay. You're back.
Okay. Let me just display it this way then, as it's not going to do it normally. So we deal with all ages, particularly those registered with a Berkshire West GP, but we also see patients who are passing through the county and quite a few people from the surrounding areas. We also look after both physical health and mental health conditions where they crop up as an urgent case. The service is delivered through triage hubs, which are telephony based, and then with a visiting GP service, and also at the primary care centres. And Sandy's going to talk to you in a bit more detail about those. We look after a population of about 550,000 registered patients. And interestingly, when you look at the numbers, Reading is by far the biggest area, but we find that most of the West Call patients tend to come from West Berkshire, the big practices, in Newbury particularly, and also some of the bigger practices in the Wokingham area. And we believe this has cropped up because of changes in those big practices to how they see and offer appointments to the patient population. And the difficulty we have is that once somebody's come through 111 and had a very fast service that suits their needs, they tend to come back again. So we're starting to get regular patients, which is something we need to look at because that's not really the remit of an urgent care service. The service is delivered by about 47 regular GPs, though we do have about 100 on our books. Of the 47, about 21 are full-time and the rest are sessional. So we're an interesting service in that we negotiate for staff each week. But because we've got so many on our longer term books who do random and very short contracts, it's meant we've been able to bring in and fill rotas through some of the very difficult periods we've had in the last year. We also have 27 nurses, 38 healthcare assistants, 29 drivers, and 36 ops and support. So it's an interesting service. Overall, we've had a 14% growth in patients that we've outcomed in the past year, above and beyond 2020. And this is now fixed. We're not seeing any reduction. It's going up, if anything. So we've done a lot of work on ways to handle the extra patients. So, for example, patients coming in from 111 come into a big list, which is called a stack. And this becomes really difficult if you've got, 50 to 100 or more patients waiting to be seen. It's difficult for staff to pick out the most urgent and to follow up on the ones they haven't been able to get through to. So we've had new software developed so that we can divide them and it self-selects into the list of urgents, which is list A, and the less urgents, which is list B. And we've then got our most skilled GP team dealing with the more complex list A patients, and the rest of the team, including pharmacists, etc., dealing with the list B. So we're doing quite a lot of innovative work, which is then feeding into the national system. I'm going to hand over to Sandy now, because we haven't got a lot of time, to take you through more detail how we deliver the service.
Thank you very much, Ben. So this slide basically shows the centres that we operate out of. So the first picture is more local, based in Wokingham. This is where our triage centre and our hub are located, as well as our district nurse team. This basically caters for GPs that are triaging on scene. We don't actually have a primary care centre at the Old Forge, but we do have a visiting mobile which is stationed to cover the Wokingham district and beyond. Our second base centre is located at the Royal Berks, where we've had many years of service with our acute trust team. Originally, before the pandemic, we were at the maternity building for many, many years. When the pandemic hit, we were relocated to the south block of the hospital. This primary care centre does have a mobile visiting clinician, as well as several GPs and paramedics and advanced nurse prescribers that see patients face to face. Our last care centre is based at Westbox Community Hospital. Westbox was originally built in 2004, and a few months later, Westcall set up a primary care centre at the Westbox, where we co-share the unit with our local minor injuries unit. There we offer face-to-face, as well as a visiting clinician, as well as triaging of patients on the stack. Next slide, please, Ben. This slide basically, I do apologise for the slightly busy slide, but we wanted to get an idea passed over as to what Westcall is doing. So originally, the service remit was to provide emergency and out-of-hours care for primary care services for patients within our locality. We're quite innovative compared to other out-of-hours providers. I liaise quite closely with Oxford and East Berks and NHUC, and we seem to be unique in our point of care testing. No other service has as many point of care testing to aid clinicians in diagnosing conditions for their patients. The benefit is that it helps to reduce the list of patients which may require a secondary care opinion if we have a CRP. We also do near patient testing D-dimers, which is very helpful in assessing patients with suspected DVTs. We provide all the care for the DVT pathway, bar the ultrasound itself. So when we get patients with suspected DVTs, we're able to offer treatment, a formal diagnosis until the definitive diagnosis is made by our excellent DVT colleagues at the Royal Berks. We also offer strep throat analysis for patients with suspected acute tonsillitis, and there is a query whether it could be viral or bacterial. This also helps to reduce our antibiotic burden to patients and helps to preserve antibiotics for long-term use by clearly targeting antibiotic use on specific patient groups. Big emphasis on sepsis. We actually, as an out-of-hours provider, have provided a sepsis kit to all of our primary care clinics, as well as our mobile vehicles. So should a clinician be faced with seeing a patient with suspected sepsis, we're able to administer IV antibiotics on scene, as well as complete a NEWS2 score, and even do a near-patient lactate testing, which is very helpful for our primary care, for our secondary care colleagues who then receive the patients. Our service is also unique in that we do have clinicians that like doing blood testing or samples being sent of urine samples. All the results are received back. I have the benefit and the pleasure of going through every single blood result and every single sample result. And in cases where patients are seen which may have been prescribed antibiotics for a presumed UTI and the antibiotics are resistant or need changing, we're able to feed back directly to the practices with those results. So that's very helpful. So the emphasis is that we're quite unique as an out-of-hours service and having this extent and breadth of point-of-care testing. Next slide, please, Ben. This is a little an idea of what kind of kit we carry in our vehicles. We have 3 mobile vehicles, as mentioned, stationed geographically to cover the Wokingham district, the Reading district, and the Newbury district. Each one of our vehicles are stocked similarly, and we can see that we have a drug bag, in fact 2 drug bags, one which includes stat dose drugs and another one which we give full course medications to our patients. It's important to realize that, because being an out-of-hours provider, we cover in times where the chemist will be closed. So we have to have provision should we see vulnerable patients unable to access pharmacy services, who live alone or have very limited care or no transport. We're able to diagnose their condition, give them a prescription and dispense on that item directly from our stock from the vehicle. We also carry catheter kits. We're often asked to provide assistance to our district nurse colleagues, who would be the first port of call. But in patients who require catheter for the first time or who have a catheterization problem, which is more difficult for our district nurses to deal with, we're often asked to come and give assistance. Other items do include our asthma bag, our sepsis and our rhesus bag and drug, doctor's drug bag also. The second picture you can see, this is one of our point of care testing, top right hand corner. It looks like a Star Trek instrument, but it's actually what we use to do point of care testing for D-dimers. The benefit is we get a result within 7-8 minutes. Patients can be given a D-dimer level, which is actually a quantitative level. It gives you an actual D-dimer score, not just a yes, no possible. So it's not a qualitative test, it's a quantitative test. And the third item was just to demonstrate what kind of IT equipment we use. So all of our vehicles, all of our mobile clinicians are able to write in real time and upload their notes onto Adastra using the laptops that you can see. Next slide, please. This is just a brief summary as to what the clinical governance behind our service does entail. So we both have a clinicians West Call practitioner and GP meeting each month, as well as a advanced nurse prescriber meeting, which is also held each month. At the moment, we're holding our meetings online, and we also use a second governance tool called Clinical Guardian. Clinical Guardian is an excellent piece of software that basically helps to gauge clinicians' review of patients to assess their treatment, and it helps to ensure that patients are being received adequate treatment, which is compliant to what NICE would suggest, and making sure that our clinicians are of the caliber to be able to safely treat and manage patients. We also have a governance lead that helps to supervise and teach, especially regarding DATEX incidences where we share learning, and that's conducted by Sharon Andrews, who's our lead for the service. So finally, I just wanted to just say that when Westcall was first instigated, it seemed to cover the primary care needs for our population in this locality, but the service has grown far beyond that. We now offer medical cover for our community wards when patients go off sick, staff go off sick, or staff actually need additional assistance to support the wards, where the A team that often gets requested to provide clinicians for the wards. We also are the glue that binds primary care and acute trust care together. Often patients are transferred from the acute trust to our community wards, where they're required to be seen, assessed, and drug charts being written up. So our service has a big impact on the community wards. In addition, we also offer excellent triaging support to our community 24-hour response team, the RAT team. When the consultants are no longer on duty, they come to us should they have a patient query regarding the patients that they see in the community. We also offer support to district nurse services, as mentioned, for catheter cares and end of life. And we also support our community for palliative care in the community, where we play a big role. We also stock controlled drugs should patients in our locality require controlled drugs to be instigated. So it was just really just to say that we're no longer just simply a primary care service. We are a be-all and end-all, and we're the link between primary care in the community and secondary acute trust care.
Thanks so much.
And now
Thank
to
you.
Helen.
Now to me, thank you. And this patient experience is not actually about myself, it's about my grandson. And my daughter was staying over the New Year-ish period with her two children, who are 2 and 6, who are both susceptible to croup. And while staying, the 2-year-old one night developed a bad bout of croup. And so she rang 111. This was middle of the night, rang 111, was directed to Westcall, and very kindly one of the GPs came out. It was wonderful with them both, and they were able to stay in the home surroundings. He gave her a dose of steroids to give them, and also very kindly gave a second dose for the next night, because often they'll have a re-flare up the next night. And it was just like, from my day, the old GP coming out to see you in the night as they did. And it seems very simple, but if I contrast this with what happens to her normally, because she lives in Chandler's Ford near Southampton, and if this happens, she'll ring 111, and basically they'll tell her she's got to take him into A&E. And so she has to get herself dressed, a very distressed child dressed, and possibly his elder brother, if their dad is working nights because he's a policeman, and pile them all into the car in the cold and go to A&E. They then have to sit there, do the registration, go through all the processes, have investigations and SATS probes put on, and then get their dose of steroids and go home. So this takes hours and is even more distressing. When I compare this service that Westcall gave to the process she normally has to go through, it is so different. And I was really appreciative of it and put in a written compliment.
Thank you very much, Helen. Okay, that takes us through all of our speeches. So if you'd like to ask any questions, please do so.
David Buckle.
Thank you really very much. So I was a local GP and I have known the service since it started, and I have to say I think it's an excellent service, and I absolutely know that my GP friends and colleagues share my view. And I thought the patient example, I work in 2 other areas where the emergency services and casualties really are struggling, and you get the sense that perhaps Westcall is absorbing more of these clinical issues and patient problems out of hours than the other areas where I work in, because there seems to be an avalanche of patients turning up at casualties throughout the country. So, I mean, every service has its problems, but Westcall has always strived to be one of the best out of hours services, and certainly it tries to adapt good practice such as near patient testing. So I just wanted to say thank you for all the times you've helped my patients, and you've done such a good job for the trust.
Thank you, David.
Thank you very much.
Mark.
Yes, thank you to the team, and also for the comprehensive range of service. I hadn't fully appreciate just really the breadth of the service that you're able to provide. Ben, a question for you. We hear a lot in the media in terms of the pressure on primary care and the challenges in resourcing those primary care practices. You mentioned you resource on a weekly basis those rosters. How resilient is your ability to meet the demands of that? Or do you experience challenges in being able to fulfill those rosters?
It's a huge challenge, and initially we didn't offer as flexible a rota as we do now. Now we will take people on for 2 hours because we can call them in for triaging. It is very hard to run a weekly roster. So what we do is we have a salaried staff who are booked onto shifts. So we fill as many as we can that way. We then next go to the regular sessional staff to fill as many more. And then after that, it's agency and the people who do the very flexible stuff. And we have found that we now really rely on people who are willing to do a couple of hours here and there, because we'll message out to them on a really busy Saturday or Sunday afternoon and say, please, can you do 2 hours? And it might be at quite a high rate. And often they'll jump on and help. And that has made all the difference recently. So it's about us being really agile on our feet. But the downside of that is it's really tough on the team, the background people who are doing the rostering, because often GPs will work for 4 different organisations, 5 different organisations, and it'll be a game of top trumps as the week goes on to see who's going to pay the most at the weekend. So you've got band 5 staff who are having to negotiate with a whole group of people who are waiting till 4 o'clock on Friday afternoon to decide who they're going to work for. So that's where it gets really, really tough, and it's hard on the team. But they've really pulled the service forward monumentally in the last 6 months, and we've survived through some really tough times. And we're now finding that doctors who left the service are coming back, which is a real validation and one we're very proud of.
Thank you.
Mark, and to add to what Ben has said already, we as a service are experiencing, the same pressures that secondary care and acute primary care are having. Patient demand is going up. One of the other innovative changes we've made is that we've employed pharmacists, advanced nurse prescribers and paramedics to support our GP colleagues. GP colleagues are quite scarce and their skill sets are quite unique. So we've built a platform where we're able to receive cases through 111. The clinicians can see what type of cases are coming on board, and our administrative team help to highlight cases which may be just a simple prescription request or a medication query, and we build that in so that the most qualified clinician to deal with that problem is allocated to that problem. So it may not need, like a GP to deal with it. The analogy is that, if a Formula One car comes in with a very sophisticated engine problem, we'll allocate that to a GP. If it's a spark plug or wheel change, we can allocate that to another professional.
And Sandy, with the rates we pay, they can probably afford the Formula One car if they're a GP.
Right, Julian's waiting for a question. So.
There's a question and a comment. Thank you for a great presentation, team. One of the things that I observe is, as you probably know, I sign off every single complaint in the trust. And what I appreciate is that Westcall is often working in very high-risk areas, working with paediatric cases where the presentation may not always be so straightforward, working with people end of life, again, complicated, and sometimes issues around pregnancy. And you deal with a huge amount of complexity really, really well, as we've just heard. But occasionally things do go wrong, because in high-risk businesses things do go wrong. The thing that I have great confidence about Westcall is when things do go wrong and people ask the question, the response you provide back to people that I sign off, I never have to send them back. They're so comprehensive, they're so thoughtful, not only in terms of the rationale and what has happened and the detail behind that, because you're very good at logging it, but also any reflective learning required for the team of individuals. And I often say to the complaints team when something else comes in, they need to take the Westcall approach about how they've used that reflective learning, really. So an acknowledgement around the pressure, acknowledgement around the risk you can manage, and the comprehensive sort of governance approach and the quality you have around there, which has consistently impressed me, I have to say. So thank you.
And Julian, just to feedback on that same theme, one of our keen interests in arranging point of care testing was to reduce that uncertainty to our clinicians. And it's a service that sometimes even daytime practice don't have the access to CRP and strep throats. We also have opened up and liaised with Westbox to be able to gain access to ICE, the pathology result system, and the discharge letters for clinical entries. And so we pass that access on to all of our clinicians. The more information you can be provided by patient's condition and test results, the reduced the level of risk that we incur.
Thanks so much, Naomi.
Thank you, Martin, and thank you, team. A great presentation, and I love the way that you've articulated your efforts to strive for excellence. It's abundantly clear. My question is a bit sort of about context, actually. I'm sort of assuming that our service, our 111 service, is not the only 111 service that services Berkshire as a whole, and that there are others. So my question is about how do we fit within 111 as a whole, as it relates to Berkshire. I think more particularly around the demand curve. You were really clear in the front end of your presentation about rising demand. So I'm kind of interested in how that demand gets managed across the county, given that I'm assuming we're not the only 111 service, or out of hours 111 service.
No, so obviously East Berkshire out of our service deals with East Berkshire. There is now a 111 Alliance where we try and have some communications around that. I think the difficult thing is that there's the playing field isn't totally level, because on one side you've got big NHS organisations like us, and on the other side you've got CIC type organisations which are more flexible around things like pay and even IR35. So we have found that when we initially lost a group of staff, they were people who were on agenda for change, and they moved to jobs which were the next band up, which wouldn't have got banded in the NHS. So there is competition certainly across out of hours and across the country, because there are more and more Bupa type services as well, offering online triage. So the conversation we're trying to have, and we're trying to pull together, particularly with the ambulance service, who allocate a lot of the 111 parts of the contract, is how do we level the playing field? And our ask to you as a board is, how can you help us level the playing field? Because pay escalation will continue to happen as long as some organisations can be more flexible in terms of how they pay. And I don't have an answer for that, except to try and provide a good service, a good team environment, good, equipment, etc. But if you're competing on £10, £20 more an hour every weekend, at Christmas and at Easter and the Jubilee weekend, you're going to have pay escalation. And once people get used to getting paid £120, £130 an hour or more, then it's very hard for them to consider working for £80 an hour.
Okay, well, I think that's a very interesting point. I was going through my mind as well, but perhaps we can discuss that at another occasion. Ben, can I just and Sandy and can I just thank you very much for your presentation? I thought it's fantastic, really important work, and actually very clearly presented. So thank you, and I hope you get some time for yourselves rather than time just for the patients. You're obviously a very busy team. So thanks so much indeed.
Thank you very much.
And I'm sure we'll be back and wanting to hear more of your story another time.
Thank you for having us.
No,
It was
it's
good
a
to talk
pleasure.
to you.
We'll let you get on to
Take
your
care.
patients.
Okay, thanks. Bye.
Right.
Well, I thought that was a fantastic presentation. Really good stuff. Shall we go on to a related issue then? Patient experience report, Debbie.
Yes, no problem. This is our usual quarterly report. I would say there's not a lot really out of the ordinary to report on this quarter. I would note though that the report does indicate we are starting to see a rise in the total contacts we're having about CAMHS weights again, both through MP inquiries, PALs, and informal complaints. But other than that, it's a pretty standard report. I did think it was really good to note the number of patient experience questionnaires that are starting to be completed using our new tool now, and that actually the vast majority of people are actually including comments for suggestions for improvement. Very few are putting nothing in that box, which is brilliant. And also to note the high level of satisfaction actually that's coming through from that, which is a real, good feel factor for our staff, as well as those areas for improvement. The other thing I would probably note is that PHSO are still way behind with their cases, which is why we've got quite a long list of cases that they are seeking information to decide whether they take forward or not. And I think that will continue to play out over the coming months, to be honest with you. We only had a couple of 15 steps visits during this quarter, mostly because COVID weights are really high again. We had a lot of outbreaks on our wards and a lot of people reverting to virtual working, but that has started to pick up again now. And other than that, I'm happy to take any questions.
Thanks, David. I've just got one question, if I may. In your cover sheet, it talks about the demographic data on ethnicity and gender, and I just remember in the past we've had a little bit of trouble getting all these stuff recorded, haven't we? And I just wondered if that was getting better in terms of recording ethnicity, etc., and all our data.
It is getting better. And we've certainly noticed, so the new patient experience tool records all those demographics as well, which is also going to be much easier. For the first time, we can really see if there's a differential between different demographics in terms of experience. So what patients are scoring into and making for improvements as well, which is really good. So we do still have some where it's unknown, but I think that is decreasing across the organisation.
That's good. Any other questions for Debbie? No? Oh, Naomi.
Yeah, just quickly, Debbie, it's probably a dumb question actually, but it's really good to hear that the I Want Great Care launch is going well and there's real momentum behind that. Very pleasing to see because I love it. Friends and family test, is it our intention to ditch that? Will we just sort of leave it behind, or is there an obligation for us to continue with it even though we've got I Want Great Care?
So what we've done is we've incorporated the two questions around how your experience was that are effectively the friends and family questions into the I Want Great Care tool. So we are still able to report against those two questions, and that's why it's been a little bit lower, because obviously we've switched off the way we used to collect friends and family and have moved to the I Want Great Care tool. So we are still, the remit and requirement now is to be collating patient experience data. There's less diktat about it being rigid friends and family only. I think in recognition that actually on its own that has actually very limited value, but as part of a suite of how did you find your stay, or the service you provided, then it's more meaningful. So yeah. Still doing it, but not in the same way.
Got it. And there's no requirement for us to report against the friends and family test in the long term. I think you've answered that.
Yeah, no, but we are, because we are collating it, and I think as part of a suite of other questions, it's meaningful.
Got it. Thank you.
Okay, any other questions? No, that's fine. Let's move on then. I think it's safe staffing next, Debbie.
Yeah, thank you, Martin. So this paper details our 6 monthly staffing review. I think what I would say is it's fair to say that over this 6 months, particularly November to March, COVID continued to have quite a significant impact on all of our metrics in this tool. To be honest with you, I would say now we are starting to see quite a significant reduction in rates for both staff and patients, and therefore we are now starting to see an improved picture in terms of shifts with one registered nurse and our unfill rate. So which is really positive. But for this report, we did have high numbers of wards and shifts with one registered nurse. Sorry, David, did you want to come in before I?
I'll ask my question at the end, thanks.
We are now starting to roll out the Safer Care tool, which allows a daily view of actual staffing versus the need of the patients on the wards, which is going to be providing us with a much greater insight into our optimal staffing, and gives us the ability to move staff around, particularly at Prospect and Wokingham and Westbox, where we have more than one ward, in order to meet the needs. I guess the punchline for me, which is what you're all interested to know, is, you know, I do think that we provided a safe level of staffing over this 6 months, although it was far from optimal. I do think that our establishments remain okay. And the challenge we've had over this 6 months is the ability not to fill all those because of COVID, and the ability, obviously, not to fill them all because of vacancy. But I wouldn't be proposing we had different establishments on the wards at the moment. That's the punchline for me, really, and I'm really happy to take any questions or queries. I know it's a detailed report. It's how we have to write it, unfortunately.
That's all right. No, it's a very important report, Debbie. David.
Thank you. Well, I recognise that Debbie, her team and the Trust always do everything they can to mitigate these difficulties, but we and the NHS are facing, you know, staffing issues. And I've got to be honest, you know, one senior nurse, fully qualified nurse on a ward is at a level that I think we can maintain safety, but probably can't maintain quality, would be my view. So elsewhere, so it concerns me. Elsewhere, the lack of available staff is even worse in certain areas in the NHS, and those trusts are agreeing local parameters about COVID testing and when staff can work and when they need to isolate. So my question is, and the reason they're doing that is that they're seeing the risk of not treating patients being greater than the risks of altering the guidelines around COVID. I don't think we're in that position, but I just want to check what we're doing as we see these pressures on staff and service, what we're doing around following the national guidelines on COVID, i.e., are we still testing patients as they say we should? Are we allowing people who've been in contact to work? You know, nitty-gritty questions like that, which affect our services.
Okay, so first I would say that unlike some organisations, we are in a good position where we have a number of supernumerary staff available to us, including our matrons, our clinical development leads on the wards, managers, who do step in and help. So whilst we are saying that this is one registered, we don't leave the wards with one registered. We would find others to be able to support, and we do that. In terms of COVID, yes, we are following the national guidance in that we are testing patients as we are expected to on admission on day 3 and on day 5 to 7. For most of those tests are lateral flow tests now, which means you get an instant result, which is a lot better than waiting 24 hours for a lab. And that means that we can be isolating patients much quicker if we need to be, which is really good. And it means that they don't have to be isolating, waiting for 24 hours. Our staff are still testing twice a weekly. As we sit today, I think we've got 16 staff off COVID related. So across the organisation now, a relatively small number, David. And what I would say is our experience has been that if you have got COVID positive staff on the wards, try as you might not to, you do get transmission. Staff to staff in particular, and we've seen that in a couple of outbreaks. So I would be thinking very, very carefully before bringing in COVID positive staff to look after our COVID negative patients, and not ending up with a bigger problem actually, because you've got more staff off poorly with it. So we are following the guidance.
Well, that's good to hear, and I think if we were ever tempted not to follow the guidance, I think the board would want to know about it.
Absolutely.
This is a public meeting, but you know there are trusts that are not diligently asking their staff to test themselves, are testing at admission day 3 and day 5, etc., etc., and that's simply because they're at a very high level of crisis.
Thank you, David. Thank you, Debbie, for your response. Naomi.
Yeah, thanks, Debbie. This is a quick one. I'm referring now to, and it sounds pedantry, but it just alerted me when I read it. Page 62 of the pack, on the second paragraph, you make reference there to some continued suspected underreporting in certain areas which experience the most challenging with staffing. Bit of insight on that?
So we ask staff to report on Datex if they think that the staffing has been less than optimal, or they've had less staff on the shift than they would want to be. We get to hear when there are problems because of low staffing, but I don't think we don't think everybody always puts in a Datex every time they're one member of staff short, for example. So therefore, when we're reporting how many Datex incidents of lower staffing than we would like, it's not, I don't think, 100% accurate, because I think a lot of the time people get on, muck in, they pull the matron onto the board or whatever and just get on with it rather than the reporting of it.
Understood. Thank you.
Thank you very much. Any other questions? Well, Debbie, thanks so much to you and your team for managing this complex issue. We're asked to note the declaration provided by Director of Nursing that we're safe in staffing. So thank you very much for that. And these are some of these things, of course, are long-term issues, aren't they, about workforce, etc., which you know is not going to be solved by some short-term action. But thank you, and to all the staff as well. Okay, quality accounts, Minu.
Thank you, Martin. Which is a fairly detailed account as always. This is for 21-22. Colleagues on the Quality Assurance Committee would have seen previous versions of this report, and the full board would have seen this virtually a little ahead of the board meeting today. I'm not going to go through the quality accounts. I think it's important to note the quality accounts are no longer required to be audited by the external auditors, so the national regulations on that have changed. And the quality accounts lay down all the data and the information which executive colleagues and board members would have seen in different meetings. So nothing here is a surprise. It is all the data brought together, and then some really good narrative about the improvements and other work which is being done. For example, our CAMS weights, which we are aware that for the autism assessments and ADHD assessments, they are high, and the narrative in the improvement section talks about
measures being taken to manage that situation. So happy to take any questions from the board, please.
Any questions? It's one of these reports that I always find useful to look back on, as it were, because it does sort of bring everything together and gives a more of a holistic view. Otherwise, you can get, at least I can get sort of sidetracked by bits of detail. So I find it a very useful report, and of course, it's been gone through every quarter. So I think there's nothing really new or surprising there, Minu, is there? It's a statement of where we are. Okay, well, we're asked to consider the statement of directors' responsibilities. It's actually on page 157 of the pack, and to ask if you will agree that I and the chief executive can sign that it conforms to the requirements. Everyone happy with that? Okay, in which case, Minu, thank you very much. If we could now move on to review of current processes against the recommendations from the final Ockenden report, 6.4. Debbie.
Yeah, thank you, Martin. So the final Ockenden report was published at the end of March. We talked about it at the last board briefly. And whilst the recommendations are focused on maternity service, it would be really wrong of us to assume that any of the lessons, well, most of the lessons in here were not applicable to any other provider. We strongly, Minu and I strongly believe that most of them are transferable, with the exception of the maternity very specific physical care provided. So Minu and I have reviewed all the recommendations and taken any that are transferable across to any organisation. Reviewed them against our current practice. I think we can take a high level of assurance that we've got good and robust governance processes in place. That said, there's always learning you can take from these reviews and improvements you can make, and we have highlighted a couple of areas where we are reviewing how we triangulate learning is probably the biggest one, to be honest with you, to make sure we're really robust. What I would also say is the recommendations in this are not dissimilar to the PASCO report, which was produced a few months ago on the back of all of the Southern Health review. That also talked about complaints handling, communication, how we investigate, structures and things in place. So there's a lot of similarities between this and the PASCO report. So it is as it is. I've brought it here for you so you can see the review that we've done, and obviously the work that we are planning to continue on our learning journey. And I'm happy to take any questions.
Could I perhaps just kick off, Debbie? Thanks to you and Minu for this. The point you raised about follow-up, I think, in your comment just now, is the one that came out to me. Was is there some work we need to do in our processes to make sure we do follow up that the improvements, etc., that have arisen from SIs, etc., are really sort of logged and not just left to sort of drift? I know that sounds a bit casual. I don't mean to imply that, but is there something just to tighten that up we need to do, or?
I think it would be fair to say that we have some areas of the trust that are better at doing that than others at the moment, and how we actually pull it together to ensure learning across complaints, litigation, incidents, and ensure that learning is embedded across the organisation and that it's happened is an area that Minu and I absolutely would want to be ensuring is as robust as it can be.
Okay, and Minu, is it the same point? Just before Minu and then Mahmouda. Yeah.
Thanks, Martin. I just wanted to qualify Debbie's response a little further, because I thought your question was more about, do we follow up on the actions? And we certainly do. I know that all actions arising from our national audit and plans there, all actions arising from our serious incidents and all our mortality reviews are followed up and closed. I think the extension of that is how much can we assure ourselves that every action leads to learning, and that is Debbie's response. And we go to great lengths to ensure that the learning is disseminate it through clinical directors and other means in the trust. The challenge always is the assessment, and the end is how much of that has contributed to real learning in the front line. And I think that remains a challenge for any of these processes. Is the process, however robust it is, we still always ask ourselves the question, and when we discuss this in governance meeting, is how much of that learning has gone right to the front line and implemented so that we don't hopefully see the same errors again. So there's a slight extension to that. If that's
Thanks, Minu.
Thank you. Mahmouda.
Thank you. I'm just wondering, because I note the Royal College of Psychiatrists accreditation for investigation of serious incidents, and how often is that revisited then? I mean, how long does the accreditation last then, and how often do we get sort of if I can call it checked to see that we're, that we are still accredited?
So it's a 3-year accreditation, but with a checkpoint at 18 months.
Oh, right, okay. So ours was 2021, so we've got,
yeah. Okay. So later on this year there'll be a checking in process, if you like, to ensure we haven't radically changed stuff, and then the total accreditation is for 3 years. So we'd be going through it all again in 3 years' time.
Okay, right. Thank you.
Okay. Anything else? Oh, Julian.
Yeah, I just want to say I found it really helpful, a bit like you said with the quality account, Martin. It was just useful just to look in sort of one place some of the processes we have, because in a sense, good governance, isn't it? It's about helping, making it easy to be able to do the right thing and difficult to do the sort of wrong thing. And actually, I could start to read through some of our processes. We've got some good established processes which we should be all familiar with, and I think it's helpful that they've been able to pinpoint a few areas where actually this report has prompted some thinking and to improve. So I thought it was a really good comprehensive piece of work that Debbie and Minu had done, and I found it really helpful to just kind of read, reflect and think about where we've got to so far with our governance.
Yeah, I agree with that. I think it's great. I think the point also Minu made about the front line, that it's always a challenge, isn't it, to make sure that everyone on the front line has got the message, and I guess our audits, etc., will help with that. My only comment, which is a general one, I've expressed it before, is that about the Ockenden is I don't seem to see enough coming out of the NHS, whether it's Mid-South, Morecambe Bay, whatever it is, to understand the governance issues to do with why these things happen, because they're all quite different, and they're all specific to their clinical area, etc. But they happen, and it's not. I'm not trying to blame anyone, but it seems something which spells out a bit more about why the governance has failed. Why the board, where these institutions has not managed somehow to see. And I know it's easy to criticise others, and I'm, your fingers crossed when you say this, but I think something more about what that's gone wrong somewhere and how we could learn from that, I think would be helpful. Minu, well, I've stimulated a discussion.
No, not at all. Not to extend this any further than what the board wants, but I think a common theme in all of this is not listening to patients. If you read any of the reports, and of course, after listening to patients, there are weak governance processes. So when these two come together, I think that sort of results in some of these sort of prolonged systemic errors just continuing. So this is not a case of 1 or 2 cases, and they carry on. So I think those messages are there, and we're quite hopeful that with the patient feedback and the willingness to listen to patients all the time, we hopefully should never. One can never say never, but hopefully should never be in the situation.
Thank you for that, Mark, and then Debbie.
Yeah, just really picking up your point, Martin, in terms of the shortcoming in governance and the roles of the board. I do think this goes back to culture and the leadership in an organisation, and to be reassured, I feel reassured as a non-exec to hear Minu and Debbie talking about, no, we're not going to put Ockenden on one side and say, no, that applied to a maternity environment, it doesn't apply to us, but to pick those transferable learning points up and to apply them to ourselves. The point I was going to make is I really feel that this would form a very powerful and useful part of Julian's presentation to the staff, his CEO monthly report, just to say, here is something that was applied for another trust, But even as an outstanding organisation, we can learn and develop what we do ourselves. And this is the learning that we've taken from it. And dispel this myth that there is any suggestion of complacency, or it just demonstrates humility in terms of we can all learn from this, regardless of what we're doing.
Thank you. Mark, Debbie, I mean, oh, did you? No,
yeah, I was just really quickly going to say, Martin, the other common theme for me in this is not listening to the staff. So not having good processes whereby staff feel that they've raised concerns and they're heard. That's a really common theme through all of the reports as well.
Thanks for that, David Buckle. Then we move on.
I was trying to answer your question, and I think, but it's really, really, really critical, isn't it, that we're not living in our own bubble of self-congratulation. And when I first looked at this, and going back to about 2012, I think the term that really resonated with me was disconnect. That the board is not connected to what's really happening out there. And Minno's right, it's about not hearing what the patients say, or just saying it's a one-off. Debbie's right, it's not hearing about what staff saying. And I think the third component I always look to is evidence-based information, you know, and then triangulating those. So I'm not saying the quality committee was perfect, but that was one of the things that I tried to do when I started, is to make sure that those avenues of information were there. And when they don't happen, you have to ask yourself, is why didn't the clinicians tell us about this issue? Because they knew about it. Were we not listening? Did we suppress it? Did they just not have the right culture, as Mark says? So to me, I put this all under the word disconnect, and our job is to make sure that there is no disconnection.
Thank you very much. Well, we're into philosophical things now, I expect, but Debbie, thanks so much.
I think it's quite practical, actually. You know, does the stuff get through to us? Yeah,
no, I understand that, but also as a wider issue for the NHS, I think. But David, thanks for that. Okay, is there anything else? No. Is Julian about to press his button? No. Okay, shall we move on then to executive report? I think, as usual, just take questions.
That's right. That's what I was pressing my button for, just to say.
Oh, I see.
A bit more content than last month, but hopefully it's relatively straightforward. And yeah, if there's any questions or points of clarification, happy to pick them up.
Anything anyone wants to raise? No, I think we're all content. So could we move on then to finance report, Paul, and then the performance report afterwards?
Okay, thank you, Martin. So this is the final finance report for 21-22. Numbers obviously subject to external audit, which we're going through at the moment, and should clear by early June. So we've finished the year provisionally with a reported surplus of 1.9 million, and that includes the previously communicated disposal of Craven Road. If you exclude the profit on disposal, we finished with a £700,000 surplus, which was 300 less than the million surplus we were forecasting. But I think still to note that's 700 better than what we planned initially for the end of this financial year. As ever, month 12, the numbers can look a little bit different compared to trend. So just a couple of points to note in general about the finances. So in month 12, we've tried where we can to maximise all of the non-recurrent funding that we received this year. So you may remember previously there'd been communication that some unspent spending review and service development funding allocations were going to be clawed back. At the end of March, the centre reversed that decision, so we were left with additional funding that we thought we weren't going to be able to utilise. So we've done what we can to spend some of that. And I guess what the report shows as you look through is a marked increase in the income recognised in month 12, as well as a offsetting increase in level of non-pay expenditure. and that's us, like I say, working through deferred income and, like I say, maximising what we can in terms of spend to provide some coverage into next year, as well as some non-recurrent items we've been able to purchase this year. Other thing just to note, which is again is a bit of a month 12 oddity, but it's a similar thing to what we've seen in the past 2 years, is the additional 6.3% employers' pension costs are included in a month 12 single one-off payment. So within our income, there's 9 million of additional allocation, and within our pay expenditure, there's an additional 9 million of spend. So that's what's driving predominantly the two variances in those positions in month 12. In terms of, like I say, we've done what we can to utilise the additional funding we got this year. So month 12, we've recognised a number of allocations that we've been able to make to independent and third sector organisations. We've been able to bring forward and increase some IT spend and IT hardware spend, as well as some medical equipping. And we've also recognised and reconciled costs that we're hosting on behalf of the ICS in terms of the temporary staffing project, which Julian's leading. Month 12 non-temporary staffing costs, you'll note, are notably higher than what we've seen in previous months. So a couple of factors at pay outside of just the general pressures on staffing, which Debbie's previously mentioned. March, we always see an increase with staff using up annual leave. So we do tend to see a £300,000 to £400,000 increase in staffing cover. But we also need to remember that back in March, we had increased levels of sickness due to COVID, which again pushed up our temporary staffing costs. We were also given the surplus position forecast at the end of this financial year, able to do what we could to try and help with cost of living. So we made a one-off payment to staff to help cover increased cost of fuel rises that came through in March and April. So there was a payment made to staff. Payment was made in April, but did what we could to try and ease cost of living costs there. Outside of the non-recurrent movements, despite all of the challenges with recruitment, we did see a net increase in workforce, which was encouraging. And our out-of-area placement costs were higher, but again, back in March, we were under significant pressure in terms of COVID outbreaks and bed closures. So that's not necessarily surprising that we saw an increase. In terms of capital, I think given everything that was going on in the past year, the team have done really, really well. We've ended up spending just 100,000 short of our system capital target of 5.8. And if you look at spend outside of that, we spent 1.5 against the 2.1 target. So I think the team did really well managing the capital spend and allocation for this year. And from a cash perspective, we finished with 53.9 in the bank, which was 8.5 higher than planned. And again, that's predominantly been driven by non-recurrent allocations that have come in and spend profile against those. And again, we still have the issues around capital control totals for next year, which puts a constraint on our ability to spend that cash, which is a frustration. The only thing not in the paper, which is probably just to note, is just confirmation that we put in our 22-23 plan to NHSI a couple of weeks ago, reflecting the 2.7 million deficit that we discussed in committee last month. So happy to take any questions.
Paul, thank you. Could I just start off about non-permanent staffing?
Yeah.
You sort of explain it away in your comments you've just made, and also in the pack as sort of a short-term thing. But if I look at the chart on on the middle of page 234, the non-permanent staffing has been increasing gradually right the way across, as has the agency component of that. And I suppose it's probably a question no one can answer, but is that really going to fall back, or is it just going to go back to the February level or whatever? See, if I just look from April 20 right way through. I know they've got COVID and all those things, but what confidence have we it's going to fall back? Because it increased agency in particular is a risk factor, isn't it, in terms of clinical practice? Just because the staff don't know the trust so well. You know?
Yeah, I mean, it's not ideal. I mean, I think I would hope it would drop back. I mean, as Debbie said, we've been under a long period of sickness, October to March, which is COVID influenced, which again, if that was removed, you would expect to see a level of reduction. But I think we've got to remember that in that period, we've seen some increased pressures. I mean, we had a presentation earlier on today from Westcall that indicated the higher rates that service will have to utilise, which is playing through, which, you know, it's not clear whether we're going to see levels of reduction there. And we're also servicing a number of our investments from commissioners with temporary staffing as well, probably more so than we have done previously. So the plan would be hopefully that we can minimise the costs where we can. And like I said, we've got plans, like I say, hopefully next year with the temporary staffing project to see some reductions in rates through controlled rate cards, etc. But I think we have got a naturally higher level of spend now than we've had previously.
That's fine. Thanks for that. Any other questions for Paul? Shall we move on to the finance report, the True North performance report then, Paul?
Okay, thanks, Martin. So again, the indicators are broadly online with.
Naomi's got a hand up.
Oh, sorry, Naomi.
I'm sorry, Martin, it was a bit of a late hand. So I asked this in the last FIP, Paul, and I'm hoping you kind of got the answer now. On the cash flow table, which we've got there on page 238 of the pack, if we look at the actual year to date operating surplus, it says 5.4, but we're reporting an operating surplus of 0.7. So I was interested in the difference.
It was the reconciliation in terms of how that's calculated through the NHSI return. So it removes elements of interest, PDC and disposal before it declares that number. So what we've said is we're going to tidy that up for the coming year so that it aligns to a more traditional view rather than the way it's reported through to the regulator, because it is slightly confusing.
Okay.
Okay. Anything else before we move on? Right, let's go to the performance scorecard then, Paul.
Thank you. So yes, again, no changes in indicators in terms of movements from red to green or vice versa, and metrics are kind of playing through in line with what we've seen in previous months. So falls still above target. Still seeing high level 70% falls unwitnessed, and majority of falls are still happening on wards where we've got high levels of occupancy. Reassurance for the board is that falls reported this month, there were no instances of moderate or severe harm to any patients this month. Self-harm still tracking significantly higher than planned, with majority of instances around bluebell and snowdrop, and we are seeing a change. So because of the work we're continuing to do, we've seen a reduction in ligature incidents, and now seeing head banging and cutting as the primary incidents being reported, and units are putting a number of countermeasures in place to try and monitor and bring the indicator down. Fire evacuation getting close to the 95% target, increased performance this month, and that's off the back of some dedicated training that we've done to ward areas in Prospect Park. Staff turnover, we've hit the highest level of turnover this year at 16.8, and obviously that's a key focus for HR in the coming year in terms of trying to manage that in terms of recruitment as well as retention piece. And again, as Debbie mentioned earlier, we're starting to see an increase in utilisation of the I Want Great Care tool, and response rate is up to 4% from 0.5% last month. So happy to take any questions.
Any questions? Tamina.
Hi, Paul. Thank you. That was really helpful. Included in the turnover figure, how does that break down in terms of staff moving into different roles internally? And do you know what the rate is of people who are leaving within the first 12 months of starting at BHFT, or is it usually people who've worked here for much longer?
So I don't have the numbers offhand, but it is something we're looking at, because obviously in the context of setting the workforce plan next year, we've assumed a quite aggressive level of growth again. I think one of the things that we need to recognise and we need to get some data on is that internal movement. But I don't have the figures to hand, I'm afraid. I can try and get them for you from HR.
Okay, brilliant. Thank you.
Okay, anything else? Fine. In which case, shall we move on? Thank you, Paul. Shall we move on to combined projects? Alex.
Thanks, Martin. So, colleagues, paper to note, generally tracking okay, some pressures around key leads, moving on, particularly in the green plan. We need to fill that and get back on track. But aside from that, you can see the key updates on our amber and red projects there.
All looks very clear. Any questions? No, I think the conclusion is correct. The workforce is obviously the big issue for us, and we've got lots of projects going on, and I guess the board will need to look at that in due course to decide whether the scale of what we're doing is sufficient, but it's very clearly set out. No comments? Okie doke. I'll get back to where the agenda. Where are we now? Audit committee. Any comments, Rajiv?
Nothing unusual to comment on. The minutes are there on page 276 onwards. One thing I will call out, which didn't quite make the minutes, which I thought was quite interesting, is I did ask Mark on the cybersecurity risk, what if he had extra budget for next year, where would he invest that budget to reduce our cybersecurity risk? And his answer was quite interesting. I'll paraphrase what he said, but he said, essentially continue to invest in the areas of productivity so that our nurses and other staff have time to take cybersecurity training and think more diligently about the actions they're taking to protect ourselves, which I thought was an interesting comment, rather than spend it on more IT related matters.
Okay, good. Thanks for that. Okay, should we move on then? Annual report, Julian.
Yeah, thank you. To note, really, Martin, there's obviously a front sheet there explaining the annual report, the process before Parliament. So yeah, opportunity just to note and take any questions.
Okay, thank you for that.
And ultimately, we're going to approve it, Martin.
Yeah, no, I understand that. Any questions first? Everyone content? Everyone content to approve? They are. Thank you, Julian, for that. Councillor Governor's update. I don't think I've got anything which I haven't you aren't already aware of, so I've got nothing new to add, apart from the fact that we the Governor's appointed the new non-executive director, Sally Glenn, who will be taking over from David Buckle, and it was a good process, well run, and we were pleased with we had good candidates to consider, so that's good news. I got nothing else. Any other business? I've just got a couple of things, which is in this meeting, is to formally thank two colleagues from the board who are stepping down. David Buckle has been with us, I think 7 years, David. I'm not sure. I can never remember these numbers exactly, but 7, thank you. But your contribution has been really significant to the trust, and your chair of the quality committee has been excellent. So we thank you sincerely for all you've done and wish you well in your other activities outside the trust. And the other is David Townsend, who's always very modest and quiet, but David has been handling a really tough job, the CEO job, for many years. I think he's far too modest and he doesn't get the praise he deserves for doing a fantastic job. David, I know you've got we've got a chance to say goodbye to you later on today, but thank you for the record, and you'll be missed. And Tamina's got a hard job to follow you. So well done and thank you.
Thank you,
Next public board meeting is the 12th of July. Is that right? 12th of July? The one in June? Oh no, public. Yeah, June's a discursive. That's all right, 12th of July. And now we'll consider our non-resolution to exclude the press and public from the rest of the meeting. Could I suggest we have 20 minutes and then we'll just get on and have the in-committee meeting. Thank you very much.